Hi, good morning. Thank you. Could I have I'm hoping that the clicker works. So they got new batteries for it. So thank you very much for being here bright and early in the morning, hopefully adequately caffeinated. I get to start us off at the very beginning of life with fetal therapy, so treatment before birth. And that's usually something at the sort of soccer sidelines when people ask what I do. It's like, never know really what to say, because when I say fetal surgery, people just give me a, what? When would that ever be needed kind of look? And fetal therapist doesn't really sound any better. That sounds like, we're treating attachment disorders really early on. So anyway, I'll just give you a brief overview of what it is that we really do and what conditions we treat. Next slide, please. Sorry, I think I'm too far away from the from the clicker here. So I'll talk a little bit about the fetal surgery program that's newly opened at the collaboration between UW and Seattle Children's. And then I'll give you a view of two of the conditions that we treat in a little bit more depth, rather than talking about all of the conditions that we treat, so that you can really get a feel for what it is that we do and why we do what we do. Next slide. So we want to treat all families in the best possible way, and the mission is to really provide appropriate intervention, diagnosis, and really wraparound care for these families. And the Fetal Care and Treatment Center is split up in the Fetal Diagnosis Program, the Maternal Intervention and Surgery Program, which is us, when we identify fetuses that require intervention via surgery or minimally invasive procedures before birth. And then there's a regional Fetal Care and Treatment Program for the clinic here, so that people can actually have care on site as well. Next slide. And so for the intervention program, there's three co-directors. There's myself and then my partner, Dr. Martin Walker. We headed the fetal therapy program over on the east side of Seattle for the last 20 years, then moved over stock, lock, and barrel with our sonographer, our nurse coordinator, pretty much everyone, to Seattle Children's. And then we had the good fortune to have Rebecca Stark join us, who is a very well-trained pediatric surgeon who worked with one of my old lab buddies, Shin Hirose, at UC Davis, and so is also fetally trained to really bring it to the next level, to be able to offer more procedures and more comprehensive care that requires more pediatric subspecialty care. Next slide. And so I'll give you a brief overview of the history of fetal intervention. And really it starts with knowing that there's something wrong. So this was one of the fallouts, the lucky fallouts from World War II, is that sonar really is what enabled ultrasound for the location in water. And the fetus, of course, is in a completely aqueous environment in the womb. So it's kind of the perfect guinea pig for ultrasound, which was developed really quite early on in the late 1950s by Dr. Ian MacDonald. And then, enterprising as we are as physicians, the first fetal transfusion did not follow very long after, in 1963 by Sir William Lyell, at that point still intraperitoneally and not guided into vessels like we do right now. But as soon as you can see a disorder, you can start thinking about, is it life-threatening, and can treatment be offered that really improves the trajectory for these fetuses for like all of their years to come. And I think that's so unique about fetal therapy, is that we get to intervene so early on, and we get to change the trajectory for kids for their many decades of their lives and for their whole families as well. The first fetoscopy was done in 1988 by Julian D'Elia at the University of Utah. And fetoscopy means minimally invasive surgery inside the womb. And I'll be talking about where that's come today. Next slide. And so what disorders are treated with fetal therapy? Obviously, disorders of monochorionic twins are kind of among the first ones, and there's a whole host of them. There's twin-to-twin transfusion syndrome. There's a subvariety of that called twin anemia polycythemia sequence. There is severe selective growth restriction, where the placenta isn't shared equally and one baby just doesn't have enough placenta to grow on. There are monochorionic twins that get their cords entangled, and there's discordant anomalies and things like acardiac twins, now called twin reversed arterial perfusion syndrome. So there's a whole host of that. And then in singletons, there are conditions that lead to fetal hydrops. Anywhere where fluid accumulates in the body that pushes the heart over, for example, for a chylothorax, or for big cystic lung lesions. There's bladder outlet obstruction that doesn't allow the urine to go outside, and then there is no amniotic fluid, which is critical for the lung development. So those were the first conditions that were really treated successfully. Next slide. And since we found that it is safe for the mom reasonably safe for the pregnancy in terms of risk of preterm delivery, indications have really expanded to those that are not necessarily lethal but can be very life-limiting. So, for example, myelomeningocele, I'll be talking a little bit more about that. Here's a picture of a baby with amniotic bands that can cause amputation and loss of multiple limbs that we can relieve by simply cutting through that band. So that's a fairly simple surgery, if you will. Diaphragmatic hernia, and then there's a whole host of cardiac or neurologic conditions such as vein of Galen aneurysms, critical outlet obstruction in the heart, as well as vasopresbia that are being currently treated with fetal therapy. Next slide. There is a collaboration of centers performing fetal therapy here in the North American region. That includes Canada as well. We were part of the founding members of that, and so you can see the map for that. And it's really because it's such a niche field, we need to collaborate with all of the other centers to really pool our experiences, have a pool of colleagues to ask, like, hey, what would you do in this situation, and design multi-center trials. Next slide. So let's talk about the twin-to-twin in a little bit more depth. So just as a refresher, zygosity is not quite the same as chorionicity, but they're related. So zygosity means is there one embryo or two embryos? And two embryos leads to dichorionic, meaning two placenta situation. So that's kind of the first bit here. So you have type of twins here, and they're always going to be dichorionic, diamniotic. Now for the monozygotic ones, this I think gets often forgotten. If they split really early, you still end up with dichorionic, diamniotic twins. So those are the ones that are same-sex twins. They could be fraternal, or they could be what we call identical, which is also a misnomer. They're just really, really, really similar. So fun fact, about 20% of same-sex twins actually could be what we call identical. So that's what I tell my moms. Even if they've had IVF with two embryos put back, you can still see monozygotic splitting in that case. It's actually more likely to result in monozygotic twins than a natural conception. So you can't assume they're zygotic because they've had IVF with two embryo transfer. Then most commonly you end up with this situation, monochorionic diamniotic twins, so that's where most of our problem cases come from. And then very rarely monoamniotic twins where they share placenta and they share the same sac. So this is kind of separate houses. This is kind of same house, different rooms. This is studio apartment. We're living together. Next slide. It's easy to identify on ultrasound. Earlier in the pregnancy, easier than later in the pregnancy. And really what you look at is the intertwin membrane. So if it's really thin and it kind of just inserts into the placenta with what we call a T sign, so there's no like flaring at the end, those are monochorionic twins. You can see there's a little bit of placental tissue that grows into the intertwin membrane here that makes it thick, especially on the sides, and that's called the lambda sign. Next slide. Oh, I think that was one too far. Yes. So what causes twin-to-twin transfusion syndrome, which is really our most common surgery and kind of our bread and butter surgery that really allows us to get good at fetoscopy? The cause is that all of these twins have blood vessel connections on the placenta. And there can be a variety of ways that's set up. Sometimes it's an area of placenta, like here, where the blood comes from one baby, goes into the placenta, and then it drains to the other baby instead. Those are the most common ones. And obviously, they're directional. Blood goes from one baby to the other. And then there's artery-to-artery and vein-to-vein connections as well that allow a little bit less acute transfer of blood, unless you have a pre-terminal event of one baby where the blood pressure suddenly drops. Then they will allow transfusion of large amounts of blood over a short period of time, which is why we can't consider these twins independent of each other. If one twin dies, the likelihood that the other will die or will have severe brain damage is high. It's over 50%. So that's why we need to intervene in cases, for example, of severe selective growth restriction if we think one baby is very likely to experience stillbirth before viability. And then twin-to-twin transfusion syndrome develops if there's an imbalance chronically over time. So one baby, we call that baby the donor, gives a little bit of blood to its sibling every day. And then over time, that kind of builds up. And we see the classical ultrasound findings of twin-to-twin transfusion syndrome. Next slide. Here's what the placenta actually looks like that someone has lovingly injected. So you can see there's a cord insertion here, cord insertion here. You can see the vessels kind of branch out like tree branches. They go into the placenta, and then they come back to the same baby. Remember, arteries cross over veins, so this is an artery here. The starred ones here are where the connections are. So you can see this is what we call the vascular equator, meaning that's kind of the watershed. And you can see that there's some connections here. You can also see that this baby has a velamentous or marginal cord insertion, and then these are not sharing the placenta equally. So that can happen with or without twin-to-twin transfusion syndrome, and is a separate complication that actually is even more common than twin-to-twin transfusion syndrome. Luckily, most of the time, we can just sit on our hands, watch real closely, deliver a little bit early before anyone runs into trouble. But it can happen with twin-to-twin transfusion syndrome as well. TTTS, or twin-to-twin transfusion syndrome, is a bad disease. It happens typically between 16 and 26 weeks, although it can happen earlier, it can happen later, and the mortality is high. Without treatment, it's about 80 to 90%. Next slide, I'm sorry. On ultrasound, this is what it looks like. So classically, it's divided into stage 1 to stage 4. We've kind of added, for our purposes, a stage 0, and I'm actually doing a Delphi expert consensus round to kind of see if we can refine this whole Quintero staging system a little bit, since most of us have like some way of saying stage 0 or pre-TTTS or stage 1A, or, you know, I've just polled people from around the country. And this just means that there's a fluid discordance, but the babies aren't sick and they don't require treatment, but they do require closer watching, and we really don't have the language for that quite yet. Stage 1 is less than 2 pockets or 2 centimeters in the deepest pocket of the donor, and more than 8 in the recipient, or more than 10 after 20 weeks if you want to go with European Eurofetus criteria. Stage 2 is the same fluid, and the donor bladder isn't filling anymore, meaning that baby isn't making any more urine. Stage 3 is critically abnormal Dopplers, and that means umbilical artery, ductus venosus Dopplers typically. And stage 4 is high drops in either twin, and stage 5, unfortunately, is demise of either or both twins. Next slide. I've already talked about saying that if you have demise of one twin, then the likelihood that the other baby will have brain damage from watershed injury and hypotension is high, and the risk of demise is very high as well. We've had a few cases where folks came to us after demise of one twin and the other baby. We could watch them getting anemic under our eyes with ultrasound, and we've been able to intervene with an emergency transfusion a few times in that case. But, you know, you have to time it just right. You have to be lucky. And we always follow up with an MRI a month or so later to see what the baby's brain looks like. Next slide. So here are the ultrasound features. For those of you that read ultrasounds, you'll be able to see. For those of you that don't, let me explain to you. So fluid is black, so there's a lot of fluid in here. This is the donor baby here that's suspended at the front of the uterus. Sometimes this gets misdiagnosed as a monoamniotic pregnancy because you can't see the membrane between the two twins, but gravity is gravity, even inside the uterus, so fetuses don't get suspended, like up against the ceiling, so that's why it's called stuck twin. And if that baby doesn't fall down here, then there's no fluid around that baby, and there is a membrane. And this is an impressive amount of fluid. I think this fluid pocket is somewhere around 13. So when we take off the fluid as part of the procedure, this would probably be about 3 liters or so of fluid, still leaving behind a normal amount of fluid, a high normal amount of fluid. We don't drain at all. And this can make moms really, really uncomfortable, cause severe back pain, rib pain, not necessarily something that they think of being related with the pregnancy. And I've seen people treated with like ureteral stents because they thought it was a kidney issue, when in fact it was twin-to-twin transfusion syndrome all along. This can be really, really uncomfortable, miserable. Next slide. So we always look at the cord insertions, because remember that vascular equator is between the cord insertions. So when we plan our surgery, we need to know where the cord insertions are so that we can construct a map in our minds of where are those connections going to be, how are we going to go into the uterus in an area that will allow us to see those blood vessel connections. And we actually always draw it literally before surgery on the belly of the mom. Here's the cord insertion, here's that cord insertion, here's the edge of the placenta, here's where we think the connections are going to be, to create a shared understanding of everyone's in the room is what are we going to be looking at? Because with the fetoscope, you see about this much of the placenta, so just a tiny bit, and it can be very disorienting if you don't really know what vessels are going to be coming from which direction. Next slide. And then the placental appearance can be pretty interesting too. This is more common in TAP, so twin anemia polycythemia sequence, but you can see that there's a demarcation line here. So this is kind of edematous and more echo bright, and that's typically the donor. And this is more like darker gray, and this is typically the recipient, more congested placenta. And this really correlates quite well with where those blood vessels meet on the placenta. So if we see that, that's an added bonus. We can add a little line saying like, yep, that's where we know the connections are. Next slide. Now in terms of blood flow measurements, this is what would make it a stage 3. So this is blood flow in the umbilical artery. So this is when the baby's heart is pumping. This is passive forward flow. it's supposed to look like that, so passive forward flow. If there's gaps in between, there's increased resistance in that placenta. That is not normal. So that would make it a stage 3. This is typically something that we see on the donor baby. Next slide. On the recipient baby, it's more on the venous side. So this is the ductus venosus, the little blood vessel that bypasses the liver in the fetus. And there's blood backing up in front of the heart here because the heart is overwhelmed trying to move all that extra blood around. So you can see heart failure, and one of the later signs for that is having reversal of the A wave in the ductus venosus. So this is a critically abnormal Doppler indicating heart failure in the recipient baby. Next slide. And then you can see discordance in the peak MCA velocities. The middle cerebral artery is a great vessel to look at velocity of blood flow, and it correlates really well to how thin the blood is. So the faster the flow, the thinner the blood, the more anemic the baby. The lower the flow, the more polycythemic the baby as well. That's a little bit less validated, but in our experience, that really has held true. So you can see in this baby's here, it's 15, which is quite low, centimeters per second, and in this baby is 57, which is really high. There's norm curves by gestational age, and we evaluate that with multiples of the median, but that is a really big difference, indicating that that baby's hematocrit is probably, 6 to 8 or so. And that this baby's hematocrit is probably in the range of 70. So those are big differences. And these babies can be really sick when they're born, even if they're at the viable gestational age. Surprisingly, it's usually the recipient babies that are sicker. It's easier to treat anemia. Apparently, you as pediatricians know that better than I do. But, IVs in these babies tend to clot off, and doing an exchange transfusion can be really, really tough to do. Next slide. And then cardiac evaluation is really important on the recipients as well. And so we typically do something called the myocardial performance index, or the TAE index, on both sides, to be a little bit more of a sensitive parameter than the ductus venosus, which is a pretty crude way of looking at it. Next slide. And that can lead to eye drops. So this is the skull here, and this is the skin around the skull. And just by the proportion, you can see that there's pretty significant skin swelling, not normal. Here's the heart in that chest. That heart is huge. There's a pericardial effusion, and there is some skin edema as well. So this was a baby with twin-to-twin transfusion syndrome that was really sick. Really confusing presentation because the donor did not look like a donor, and this baby with full-blown recipient disease. So there's all sorts of variations that doesn't necessarily fit the Quintero staging criteria. Next slide. It can go as far as having a circular shunt. So here is, a 3-vessel view, and it should all be the same color. And the blood literally is coursing around the foramen ovale and then the ductus arteriosus in a circular shunt type thing, which has been described in about 10% of recipient cases. So really massive regurgitation in the heart and really not much forward flow going through the body. Next slide. Obviously not good. So here's our OR setup. This is the fetoscope that we use. I've included dime there just for size comparison. So it's small. I typically say about the size of a Starbucks straw or a Capri Sun straw, something like that. Single insertion technique, and then we have our tower here with the laser, the light source, the camera. So here's the laser, light source, camera, video capturing equipment, and then we have a fluid management system so we can infuse or draw fluid off, usually draw a lot of fluid off at the end. Here's our sonographer here in the OR kind of guiding us to where we need to go. Next slide. Since he couldn't be with us here today, this is my partner, Dr. Walker. We try to do all of our cases together, especially if they're more complicated, although they could technically be done by one person. And here are our new digs at the University of Washington, beautiful new big operating rooms. Next slide. So laser targets, can you push, there's some animation in there, so just go forward and push both of those. So initially when people started doing this, they did non-selective coagulation, so meaning all vessels that cross the intertwin membrane were ablated. Now some of those don't actually connect, so we've got more selective and just do the ones that are anastomotic vessels. So for example, if the membranous reflection was right here, it is usually closer to the donor than it is to the recipient because the recipient side is so expanded with all that extra and massive fluid. Then we'd be knocking off this vessel and this vessel here, some perfectly good placenta for that donor baby, so we don't want to do that. Next slide. Oh, yeah, just go forward for the animation here. So, no, actually, go back one slide. Sorry. So here are the anastomoses. I thought I had something here. But here are the anastomoses on the placenta. So remember, again, arteries cross over veins. Next slide. And here's a video. And I think, yeah, so we go into the uterus. No, I think go back one slide. I'm sorry. That was, Yes, and then we just need to play the animation on that. Yes. So you can see under ultrasound guidance, we put our little straw here into the uterus, avoiding the placenta, avoiding blood vessels, advancing the camera through our blue cannula here, and that is the recipient baby. So you can see some hands, there's the nostril, all looks pretty big, some snot already. Milk mustache, there's the mouth that you see, and then fused eyes, this is around 21 weeks. Parents are typically really excited to see their babies. And then you can see the donor baby here that's behind the membrane that really doesn't have a lot of fluid. It's kind of like having a pantyhose, sheer pantyhose draped over. And you can see that, that semi-opaque line here, that's where the membrane folds over on the recipient side. So that's kind of where you look for vessels coming from the right will be the donor vessels, and then from the left will be the recipient vessels. So this is the donor vessel, here's a recipient vessel. They branch out like tree branches, so that's how you know what direction you're going in. And then you can laser them on either side, really, of that connection. The actual connection, of course, are the capillaries deep in the placenta that we can't get to and don't need to get to, really. And we try to preserve as much placenta for each baby as we possibly can. So if there's a single vessel leading to one baby and a paired vessel on the other side, it can be like three-way kind of connections, then we preserve that. Next slide. Now, because this can cause us to miss some teeny tiny little vessels, there's a technique called Solomonization based on the biblical King Solomon that was added, which essentially means that you're lasering your vessels, like I'm doing right here, and then you add lasering a thin line across the placenta to that, just in case there is a small blood vessel that really can't be seen with the naked eye, or because the placenta is a growing organism and a growing organ, and there's a blood vessel that might develop later in the pregnancy. So really kind of just painting on the surface of the placenta there. We use a little bit less energy, draw back a little bit. And the laser, by the way, is optimized to be absorbed by red blood cells to minimize placental damage. So the wavelength really tries to cause as little placental damage as possible. It probably goes down a couple of millimeters. Next slide. And here's what this looks like after birth. So you have created kind of the wall of Berlin here in the middle. And because the placenta is a little bit more fragile there, as it gets handled, there's often a break there that you can see that wasn't present in utero. But then once you pull it out and the lab handles it, that's kind of what it looks like. And you can see there's a slight discordance here of territories. This is probably 40%, this is 60%. Usually that doesn't cause too much trouble. Next slide. So how do we know this is the best treatment? So there was a landmark trial published in 2004 that really compared in a randomized fashion laser ablation versus amnioreduction, which had been the previous gold standard treatment. This is where you just treat the symptom of polyhydramnios and take off fluid. Now, because it doesn't fix the underlying problem, it needs to be repeated a whole bunch of times. So often these parents, these moms had 3, 4, or 5 procedures done. And of course, it doesn't stop the disease progression if you've got sick kids. So it's a temporizing measure. Next slide. And here is what they found. That laser, the trial was actually stopped early because laser was superior to amnioreduction in this. This is what you want, 2 survivors. So instead of 26%, you had 36% of 2 survivors at birth. And this here's what you don't want, pregnancy loss, so 0 survivors. So about half with the amnioreduction and a quarter with the laser. And this is 1 survivor at birth. Not ideal, but you know, sometimes it's just inevitable, especially if one baby is already really sick. And I think that one of the reasons that this had more pregnancy losses is that if you lose one baby, you have a high risk of losing the other one. Whereas after a laser, you've protected the other baby, and in general, that baby will do fine. The average timing of delivery was also quite different, with amnioreduction having a much earlier delivery than laser. So this has gotten to be the gold standard. Next slide. And here are our outcomes in blue, and comparing that to a meta-analysis of like 2,000 cases or so. This is our cases when we looked at that. We're up to about 600 now, and our outcomes have stayed very, very steady. And they're a lot better than the Eurofetus outcomes. That is because as a field, of course, we have learned, you know, how to do things better, not to ablate anastomoses, and we've benefited from some of the early pioneers who made some of those mistakes that we haven't had to make. But still, we're quite proud of our outcomes, and you can see our pregnancy loss rate is now about 5%, down from 25% in the Eurofetus trial, and our 2 survivors at birth is 74%. I don't want to minimize this. We still lose 1 baby about 20% of the time, and that's always a tragedy, and often it's because that baby is also very growth restricted, if it's the donor, or if the recipient is already quite sick and we're a little bit late to the game. So people are trying to figure out in early twin-to-twin, stage 1, for example, does that justify the risk of surgery? Because what's the risk of progression? What are markers that we can learn from that these pregnancies are not going to do well with expectant management? Next slide. Here's just, sort of a slide putting it all together, how we've progressed over time here from, this is Eurofetus results, 24% pregnancy loss to 5%. And 1/3 to essentially 3/4 of double survival. Next slide. Neurological outcomes are also better. So really the most important thing here is that cystic periventricular leukomalacia with laser 5%, in the amnio reduction arm it was 10%. So we're having the risk of severe neurologic impairment with laser compared to amnio reduction. And keep in mind that for MODI twins, the risk of having some kind of neurological impairment is pretty high at baseline. It's probably about 4 to 5% at baseline already. So next slide. And this is really what we live for. It's the healthy double survivors. So one of these was that really hydropic baby that I showed you earlier with a really awful heart. They did really, really well. And they're, I want to say 8 now, and she has not required any heart surgery. She's still in the care of a cardiologist because of some valve dysfunction, but has really thrived. So obviously that's kind of really what we want. All right, next slide. Okay, we're going to switch gears and go to the next condition that I want to talk about, which is spina bifida and prenatal repair of myelomeningocele. Next slide. I'll take you through a brief tour of history here with the rather strange things that people have tried for this. So this has been known for a long time that this is a disease. I think even in Egypt it's kind of been described that there were royal kids who had this condition. And even Hippocrates, our father, kind of promoted trepanning in terms of releasing the pressure in the head that they apparently knew existed with spina bifida. Obviously that treatment was not too successful. Next slide. And then they did all sorts of stuff with that, so involving twisting tree bark around the patient's head and inserting it into the opening made from the trepanning procedure. Also doesn't work. Next slide. So before 1960, really postnatal surgery wasn't really a thing either, and the majority of those babies died. So, and then in the 1960s, the concept came up of immediate postnatal repair, and that led to a 75% survival. So this is fairly recent, really, that there's successful surgery for that, even postnatally. And initially, there was a big outcry that you were playing God and that you were having kids survive that weren't meant to survive. So really quite surprising for us from the current standpoint. Next slide. And so here is the number. So worldwide, pretty big problem. About 300,000 infants are born with neural tube defects, and especially, of course, in low-income settings. Next slide. So in the U.S., approximately 1,000 babies are diagnosed in the mid-trimester with spina bifida. And really, folic acid or supplementation has really helped decrease the number to that. Next slide. And the postnatal repair is currently the gold standard. So usually a cesarean is performed prior to labor because they're concerned about labor, really, and vaginal birth, making the, contaminating the wound and causing infection and also putting pressure on it. And then surgery is usually done in the first 48 hours with a multi-layer closure of meninges, fascial, subcutaneous, and skin layers, so in multiple layers with loops, and kind of trying to complete that interrupted neurulation process. Next slide. This is kind of what it looks like. It looks really fiddly, so they do it with loops. So you're putting together the meninges, and then here's kind of the next layer that you put together, and then you have this is the dura here. So this is the neurulating the placode. This is really what it looks like, an open spina bifida, and then closing the muscles and the skin over it. Next slide. And then you want to have a watertight closure so that the fluid doesn't leak out. And here's, of course, what it looks like. So this is really important because that's really what we want with prenatal repair of spina bifida too, is that watertight closure. Next slide. So the outcome from standard management is that most kids require a shunt, 96% here, and that they don't walk very well. Next slide. And then at 30 months, that's kind of the same. It's kind of hard to see the slide here, so it's a little bit wordy anyway. So just, there's problems with bladder and bowel function. Obviously, the neurologic lesion tends to be worse, and then tethering can contribute to that as well. And intellect is usually preserved. Next slide. So fetal repair, why fetal repair in the first place? Next slide. Well, there's a thought about a two-hit hypothesis, meaning that you have the initial defect, and then it gets worse because of exposure to amniotic fluid or movement or tethering. So over time, that it is progressive in pregnancies and has lifelong implications, and that can be ameliorated by intervening early, and that you can prevent some of these secondary effects like Chiari malformation, need for shunt, and things like that. And this is actually near and dear to my heart because in 1996, when I was a OB/GYN resident in Munich, Germany, I read about this and I thought, like, wow, this is really cool. So I got myself a grant, went over to UCSF where some of the research was being done in Mike Harrison's lab, and got to participate in the sheep studies there that led up then to the human trial that then now is leading up to the proliferation of spina bifida centers. So we used to go out to UC Davis and do our sheep work there because they have an amazing sheep facility, and create the lesion in fetal lambs, and then come back a few months later, repair them, and then compare the non-repaired to the repaired sheep. And sheep are great because they don't labor, so we don't really have lots of problems with preterm labor. The fetuses are about the same size as humans, so the size relationship works. And their placentas are really interesting. They're just polka dots all over the uterus rather than one placenta, so the placenta is never really in the way. Next slide. And so based on that animal data, people went out and started doing this in humans, most notably at Vanderbilt, and then Scott Adzik at CHOP as well. And Tulipun and Bruner from Vanderbilt were the first ones to report that, and they reported, compared to historical controls, that they had less hindbrain herniation, so less of a Chiari malformation. And that's important because that's associated with less need for shunts. And shunts, my neurosurgeons tell me, are a huge deal over the lifetime of a kid and require lifelong care. They are at risk for infections. They often get clogged. So being able to prevent shunt placement is a big deal. So lower shunt requirement. And they didn't really find anything in terms of level of leg function. But we'll see in the randomized trial that followed what that looked like. And so that prompted calls for a controlled randomized trial. Next slide. You can imagine that that is not a small undertaking. You're randomizing people who are pregnant to surgery or not surgery for their precious baby. In addition, the moms who had prenatal surgery had to stick around. They had to relocate with a support person to the trial center for the duration of the pregnancy. So it was just a huge logistical undertaking, but they got it done. Pretty amazing. It's called the MOMS trial, a randomized trial of prenatal versus postnatal repair of myelomeniingocele. Next slide. The results were published in 2018. Here's kind of how the randomization went. So there were about 140, so 91 in each arm. Next slide. How they did it. So a general anesthetic in mom with tocolytics, a laparotomy, and then a 6 to 8 centimeter hysterotomy. And then essentially what you would do postnatally, the neurosurgeon did prenatally with loops, doing that multi-layer closure. Next slide. And here were the results. So fetal repair versus postnatal repair. And the shunt requirement was halved, which is pretty impressive. Hindbrain herniation was decreased as well. Brainstem kinking was decreased, and that kind of all feeds into the need for shunt, obviously. And walking independently was doubled. And then there was a difference, or I guess there was not a huge difference here in the motor versus anatomical, and a little bit less bladder trabeculation. So there did seem to be benefit, even though this is not a lethal condition. Next slide. What about the maternal outcomes? Obviously for mom, this is a much bigger procedure than what I've shown you before with the fetoscopy. So there is risk to mom. It is not, it's a major surgery. It's an abdominal surgery. And because of pregnancy and the need for tocolytics, the risk of pulmonary edema was not insignificant. There was membrane separation. There was oligohydramnios, meaning that you can't seal the membranes appropriately anymore. Risk of pre-prom was pretty high. And the average gestational age of delivery was lower. Not terrible, 34 weeks, so fairly acceptable compared to 37 weeks. But, 3 weeks earlier. Next slide. The The question is really, these were under trial conditions. How do these results hold up in real life? So just last year, the study came out looking at a pretty robust number of, I want to say in the several, like close to 1,000, of kids who have since then undergone the procedure. And they compared them by center. So to eliminate any kind of biases, some centers place a shunt early and aggressively, other centers place it later, so they really compared from the same center to be able to have that comparison. And really the results held up pretty well. In addition, endoscopic third ventriculostomy has entered the armamentarium instead of a shunt. And the results were pretty consistent though. Fetal repair, about half the shunt needs. About the same amount of shunt revisions. So you could argue like, well, maybe if you're placing the shunt later, it's going to be a more complicated shunt. But no, that was the same. Carry decompression was required in less than half the cases. And tethered cord release was the same as well, because the concern was, well, if you repair it earlier, that then you need to have more shunt revisions. Next slide. But at what risk to mom? This is a great meta-analysis looking at open fetal surgery versus fetoscopic fetal surgery. And this is for open fetal surgery, all open fetal surgery, because the numbers are just too small. You can see that the risk for mom for complications is about 20%, and about 5% severe complications, including hemorrhage and placental abruption, bowel obstruction. Next slide. You can see that in fetoscopic repair, much less likely, only 6% of complications. So that's obviously a big deal. You have a quarter of the complications in fetoscopic repair. So that's the allure of the fetoscopic approach. Next slide. And the reproductive outcomes are also much, they're an area of concern for open fetal surgery. Next slide. So a paper looked at 52 outcomes after 20 weeks, and the rupture rate was 10%. And with 2 fetal deaths out of 50 pregnancies. That's pretty high in my opinion. And the uterine dehiscence rate was 17%. And this is pre-labor. We think of uterine rupture being about 10% risk in labor after a prior classical cesarean section, so this is higher. So clearly not super benign. Next slide. So while in utero repair is now the de facto gold standard, at the cost of increase in maternal morbidities and future pregnancy complications, so people have really looked hard at fetoscopic approaches. And I'll go through those relatively quickly. Next slide. Next slide. So there's an approach open mini hysterotomy, laparotomy, assisted fetoscopic, and purely percutaneous. So you can see there's still a variety of approaches, and we're trying to figure out what the best one is. Next slide. And this is kind of what the open approach looks like. And this is what the mini hysterotomy looks like, pioneered by Mexico. So the incision here is smaller than the lesion, so you have to kind of maneuver the baby up and down through the lesion with that. Next slide. The one that is probably gaining the most traction is the one pioneered by Belfort from Baylor, which is a 2-port technique where you do a laparotomy, you exteriorize the uterus, and then you do a 3-layer closure. And since then, they've completed 110 patients. Next slide. And this is kind of what their setup looks like. It's pretty complex, obviously. You have like 2 teams. You have the mom team, you have the baby team, you have several scrub teams. Next slide. You have all these people kind of talking, around the mom. Real estate is at a premium there because you have MFM, pediatric surgery, neurosurgery, anesthesia involved. Next slide. And the results are good, though, with a pre-prom rate of 29%, still fairly high, but gestational age at delivery, 39 weeks, not bad. Still same results of hindbrain herniation and a low rate of shunt needs, and oftentimes better than expected function of the lower extremities. Next slide. Let's skip that one, that video here. Next slide. Yeah, I'd have to switch to YouTube. Let's not do that. So here's really looking at all these different repair techniques. So postnatal repair, open fetal repair, mini hysterotomy, laparotomy, assisted 2-port, 3-port. What you can see is the percutaneous is tempting, where you don't do a laparotomy, but the gestational age is really quite early, 32 weeks. It has a higher risk of pre-prom, so people are not quite going for that. So the laparotomy-assisted 2-port seems to have the latest gestational age, and the outcomes for all of these are all actually quite good. So I think here is kind of where it's shaking out, which probably is going to be the best technique going forward, is to avoid major morbidity and still have good maternal outcomes, fetal outcomes. Next slide. Here is, again, need for shunt, just kind of putting that all together. So I think all good outcomes in terms of need for shunt. Of course, here's the postnatal repair. So this is what you're comparing this to. And I think pretty solid that all of these repair techniques have a lower need for shunt and better levels at birth, meaning that you've preserved some of the leg muscle function. Next slide. So in conclusion, the repair does improve neonatal function and reduce shunt requirements. The open fetal surgery is the gold standard, but fetoscopic techniques are certainly emerging as better for moms and hopefully equal in terms of outcomes for fetuses. And our plan is to start with open and rapidly move to fetoscopic repair. There's always going to be some moms where open repair is going to be the better choice for them, whether that's because of placental position or it's their last pregnancy. They're not planning on any future pregnancies and they just want the gold standard. So thank you.